I have two talks really. The first one is about the knee, and this is about the fundamentals of the knee. It's a very basic talk on trying to understand the principles upon which this surgery is based. And the second is on the hip, but I changed it a little bit. So I'm going to talk about the strategies in doing a hip replacement in a young patient, and I'll also tell you why I think it's an important. It's good to know what are the changes that you need to do there. So so total knee arthroplasty is one of the most successful procedures, surgery of the century. In fact, it's been voted as one of the most successful procedures of the century, not just in orthopedics, but in any surgery whatsoever. And this is a quote from one of the textbooks. Now, what are the indications for doing a total knee arthroplasty? And I think the only real indication is intractable pain. And the surgery is offered only when sufficient conservative treatment has failed. It is usually better suited for the, does this work? So it's more suited for the elderly patient. Hello, yeah. Elderly patient, and it's not perhaps a very good surgery for the very, very active patient. So it is more suited for the relatively sedentary patient. The clinical objectives, really the most important thing is the relief of pain. The rest of it is sort of corollaries and they follow. But if the patient does not have pain, then it's probably not a case for a total knee replacement. Now, what are the contraindications? Any infective etiology, one has to think twice. It's not an absolute contraindication. So even in a septic scenario, if the patient has been asymptomatic for a number of years, we could still offer it. Tuberculosis is not a contraindication for total joint replacement. In a neuropathic joint, one needs to be very careful because there's a high rate of failure and one needs to modify techniques. Of course, then you have local situations where this surgery has to be offered with some caution. Now, I think this is an important slide. The questions to be asked before embarking on total knee replacement. The first one is, does the patient need the surgery? So, what is the life expectancy of the patient? Is the patient going to outlive the implant? Is something that you'll need to address. Also, in the patient who is too old and doesn't have sufficient years to live, perhaps is also a contraindication. Is the patient medically fit? You don't want a medical emergency trying to save the knee, So that's again an important question. But the most important is the source of pain. What is the source of pain? And I will request all the young surgeons to pay particular attention to that. You must be 100% sure that the pain is emanating from the knee. Very often you have pain which is being referred from the spine or even from the hip. And if you do a total knee replacement in these cases, they're going to fail dramatically. So is there any coexisting neurological condition? Patients with dementia, with advanced Parkinson's disease, they don't seem to do as well. Patients with neuropathies, advanced diabetic neuropathies or neuropathic joints, they don't do all that well. And always do the surgery after a fair trial of conservative therapy. Don't jump for the surgery as the first option. That is given in the book by the AAOS as well. The AAOS says that the gold standard for end-stage joint disease is total knee replacement after a sufficient trial of conservative therapy. Okay, so this is, I think I'll go very quickly, pre-operative assessments. Again, I said the source of pain has to be clear. Must examine the hip and spine, look for systemic disease, infection, and is the patient immunosuppressed? And if so, then I think one needs to be very cautious and counsel the patient accordingly. So what is the deformity? Is it varus valgus, recurvatum? Is there the rotational component? Is there instability? This has to be addressed during surgery. You must provide stability in these joints. What is the range of motion? How much can you increase it? Scarring, presence of bone loss. This has to be corrected. And of course, it's good to score the knee, because that is one of the objective methods where you know what is the disability. And if you score this knee pre-operatively and post-operatively, then you know whether you've done an adequate job. Templating is perhaps more useful in the hip, but in the knee you can still do a templating, so that will give you an approximate idea of the size of the implant to be used. How much is the deformity? You need to measure it so you know your resections, planning of bone resection, whether you need grafts, metal augments, determine the anatomical and the mechanical axis of the limb. We'll look at this in some more detail subsequently. Osteophytes which need to be removed at surgery. Okay, so the common surgical approaches, you have I have to be a little brief. I can't really go through this whole thing in 15 minutes. So medial parapatellar is by far the most popular, but there are some people who go for the subvastus, midvastus. The lateral approach has been is useful in very, very tight fixed valgus deformities. You could use the lateral approach. The release is a little bit easier. You can do that. These are basically revision approaches where the quads turn down, the quadriceps snip, and the tibal tubercle osteotomy. Okay, so what are the surgical objectives? There's this correction of soft tissue imbalance, restoration of bone defects. The axis of the limb has to be restored. Creation of equal flexion and extension gaps. So these are the two areas which I will deal with in some detail, because that really is the fundamental basis on which this entire surgery is based. Implantation, correct in the three-dimensional plane. The robotics has come in a big way in this particular area, and of course achieve correct patellar tracking. So surgical goals: restore alignment and achieve equal and flexion and regular rectangular flexion and extension gaps. If you achieve these two, then you have achieved your goal of surgery. So component alignment is the single most important determining factor in the longevity and function of total knee arthroplasty, apart of course from other things. And there are three philosophies. The oldest is the anatomical alignment, propounded by Hungerford and Krakow. And then you have the mechanical alignment of Insall. And then this is the newer concept which is coming in of kinematic alignment in the paper by Hollister and Howell. We'll go through these in a little more detail. So the first proponent was Hungerford and Krakow about the anatomical alignment. This is a lot of measurements and degrees given here. The reason, why all this is important is because of the femoral offset. Now, the femur is not a straight bone. It's got the neck and the head, which is away from the axis of the bone. That's what leads to all this confusion. So, it's determined by here we are still concentrating on the anatomical axis. The anatomical axis of the mechanical and anatomical axis of tibia are the same. But in the femur, there is a difference, and that's what complicates everything. So the femorotibial angle is about 178 degrees, and is slightly less in females. This is also dependent on height. Shorter the patient, the more is the less is this value. Taller the patient, higher is this value. So the joint line is about 2 to 3 degrees varus to the horizontal. And the philosophy here is to anatomically recreate the joint line by resecting the tibia 2 to 3 degrees of varus and the femur at 8 to 9 degrees of valgus to achieve a combined valgus angle of 6 degrees. So this was the first concept, but it's a little bit cumbersome because it has these odd numbers which are extremely difficult to replicate in your in a practical operative scenario. So that's why what happened was that John Insall came up with this concept of mechanical alignment. Now, if you see this picture, the center of the femoral head, center of the knee, and the center of the ankle, they come into one line. And this is the mechanical axis. It is slightly different in the femur from the anatomical axis, which is this. And you see, in the tall patient, this difference is less. In the short patient, it can be quite a lot, 11 degrees. So the whole idea is to restore this vertical axis or the mechanical axis of the limb. This is how Insull, that was his philosophy, and the whole surgery was based on this. Even today, I think a vast majority of orthopedic surgeons follow this philosophy, and it has given excellent results in the vast majority of cases, barring a few. But it's a philosophy which is still, I think, most widely accepted, and almost all instrument systems follow this philosophy. So the philosophy is to restore the mechanical axis by making the distal femoral and tibial cuts perpendicular to the mechanical axis and 3 degrees of external rotation to achieve balance and flexion. So that's what you do. Actually, this is just sort of covering it. So you make, this is the jig to cut the tibia at 90 degrees to the vertical, and this is in flexion that you rotate the femoral cut externally to achieve this rectangular gap. So that's the rationale of the mechanical alignment. However, there are about 20% patients who are not happy despite a perfectly done surgery and despite perfect x-rays. And the reason this has been criticized is that these are measurements in a static frame, and that these, although they look very good in extension and in 90 degrees of flexion, but when you look at it throughout the range of motion, then there is a slight imbalance. So that this is really not in perfect balance in motion. They are in balance when they are static, but not in balance when they're in motion. And that's the reason why Hollister and Howell came out with this concept of kinematic alignment. Now, what they say is that there are 3 axes that govern movement of the tibia and patella. So the fundamental difference is Insull viewed his alignment in a static situation. Howell looks at it in motion or a dynamic situation. That's why this is called the kinematic alignment. Now, the first is a primary transverse axis. So this is basically the axis, and these are all horizontal axes actually. So this is the axis around which the tibia rotates around the femur. So this is the axis to the center of a cylinder that fits the articular surface of the femoral condyle, and the tibia flexes and extends around this axis. So that's the primary transverse axis. And then you have the secondary transverse axis, which is parallel but anterior, and here this is the axis around which the patella rotates around the femur. And then there is the longitudinal axis of the tibia, which is perpendicular to these two, and this is where the tibia rotates internally or externally. So it needs a little bit of imagination if you can visualize or conceptualize these three axes. The problem is that these 3 axes are not orthogonal, or they are not parallel or perpendicular to each other. That's the problem, which is very, very difficult to replicate. So, in kinematic alignment, the goal is to align the transverse axis of the femoral component to the primary transverse axis of the femur, to which the tibia flexes and extends. And this is achieved by a technique which is called shape matching. Now, this is a very difficult procedure to do with the currently available jigs. This used to be done by a particular software. It was a computer software which was utilized to make the patient-specific jig. So all this was incorporated in the patient-specific jig, which you applied on the femur, and then you did the cuts. So the philosophy is, if you try to understand, it's a little more difficult to understand than Insull's. This is the great advantage of Insull's philosophy. Is it was very easy to understand, straightforward, very easy to replicate. 80% you have no problem. So why not do it? So it's just for that 20% that all these things are coming in. Now, the whole idea is to restore the femur to the pre-morbid state. Before the femur became arthritic, that's the state to which it is restored. And then you sort of match the tibia to the femur. This is the original kinematic, the concept of kinematic alignment by Howell. And so, tibial alignment is complex, involves 3 steps. The AP axis of the tibial component is placed perpendicular to the transverse axis of the femur. This is easy to understand. Rotational alignment of the tibia to the tibial component is achieved. But the center of the tibia is placed under the center of the tibial component, and this normally leaves it at about 3 degrees of varus. So, just cutting the tibia in varus is not kinematic alignment. When you follow these principles, you usually end up leaving the tibia at 3 degrees of varus, not at 90 degrees to the horizontal. So, basically, you shape match the femur and then gap balance the tibia to match the femur. So, that's the concept of kinematic alignment. So, what is the process? It requires appropriate software to create a 3D model. This was in the pre-robotic days. Today you don't need it. Once you have the robot, you can tinker every 2 degrees or 1 degree or half degree, and then you can actually achieve the same thing. Another software converts the arthritic knee model to the normal pre-disease knee specific to the patient. That is the USP of this technique, that it is patient specific. Each patient, the knee is placed differently. In Insol's concept, all the knees are brought to the same standard. And that is why in 20% cases there is a dissatisfaction. Here you are matching the knee. It's like, in other, what you're doing is you're cutting the leg to fit the suit. But here you're cutting the cloth to fit the leg, which is far more scientific. But we'll see what are the problems. So it kinematically aligns the components by shape matching, and the best way to make the best fitting femoral and tibial components of the pre-disease knee. And the 3D position is transferred to the arthritic knee model with a patient-specific cutting jig. Today we do this via the robotic. Okay, now suppose you don't have all this, can you still do it? So this is the kinematic alignment technique by using the jigs. Can we perform with modified mechanical jigs? Removal of all abnormal osteophytes. That's the first step. Then equal femoral cuts from both condyles of the same thickness as that of the femoral component. Today, all of you who perform knee replacements will know that invariably you cut more on the medial tibial condyle and less of the lateral tibial condyle. But in a kinematic philosophy, you take equal cuts. Also, tibia is then so that's how you do the femur, and then the tibia is gap balanced onto the femur. Collateral ligaments are not released, but allowed to reach to their full length. The posterior capsular release may be needed. That is to correct the FFT. But the important thing is you do not do any collateral ligament releases. So that's where Howell says that, the classic statement of Insol was that knee replacement is a soft tissue surgery. And Howell says exactly the opposite. This is not a soft tissue surgery, this is a bony surgery. So that's how you can still do this mechanically. Now, what are the mechanical advantage? What's the disadvantage? The patient satisfaction has been challenged. So 20% patients, despite excellent x-rays and excellent surgery, somehow are unhappy. Now, and the reason is that this is a static measurement and has no bearing on kinematics. Perfectly aligned knees, even by computer-assisted surgery, have a dissatisfaction rate of 20%. Mechanically aligned knees actually kinematically malaligned. And Morgan et al. Have found no difference in survivorship in neutral varus valgus alignment, provided they are balanced. So that's the disadvantages of the mechanical. But kinematic alignment, what are the advantages? It's a 3-dimensional alignment which restores motion and obliquity, does not disturb collateral ligaments, so the normal kinematics between the components are maintained, and a level 1 RCT by Dorset. This is very important. Alignment, and there was a faster recovery because but however there are risks. Now, studies have shown survivorship in mechanical alignment knees have found that implant survival is best with a little bit of valgus. Varus knees fail due to collapse. Jeffrey showed 3% loosening when the mechanical axis passed it was mechanical alignment is off 3%, is more than 3%. If it is malaligned, there's a 24% of failure. And in Dorset series, the number of outliers with unsatisfactory results were more in the kinematically aligned group. So what is the gist of it all? That theoretically kinematic alignment is good, but practically it's a very difficult goal to achieve. When you do this perfectly, you have a very happy patient with very good results. But if you are slightly off, then it ends up with a disastrous result. If you read Nakamura's paper from Japan, you find disastrous results when with the kinematic alignment. So the gist again is, so the new concept has come in, which is called restricted kinematic alignment, that you do kinematic alignment but keep the mechanical alignment in the background. Okay, so just very quickly through the technique, the gap balancing technique. There are basically two techniques: gap balancing and measured resection. So here the bone cuts are taken perpendicular, and then extension gaps are done by soft tissue releases, and measured dissection, the bone gaps are taken to achieve the dissection. So just quickly going through this, so it's a bit of a challenge.